Hi, my name is Nam. So I'll be giving you a brief history about Pilates. So it was Joseph Pilates who first designed the Pilates method. So he was a nurse physiotherapist during World War One, and he used bed springs and attached them to headboards and footboards and bed frames, and came up with the primitive Pilates equipment, which today are called the Universal Reformers and Trapeze Table. So the philosophy behind Pilates, that was previously called contrology, was to activate brain cells to stimulate the mind and the body, which would lead to a holistic and balanced well-being. Pilates designed the apparatus to help people learn movement patterns that would that would ultimately be functional and integrated. So the central principle of Pilates was the mind over matter concept, with the goal of fusing the mind and body so that the body could achieve greatest mechanical advantage in order to achieve optimal balance, strength, and health. Further, Pilates also believed the core to be the powerhouse, and hence centering is the focal point of Pilates today.
It was reinforced motor learning by modifying and focuses on the body movement and posture. In 1915, the term contrology was introduced by Pilates, which simply means development of the human body uniformly and correspondingly. Pilates was also emphasizes the posture as well as integrated the whole body activity. Muscles not primarily to be moved, pattern remain actively engaged and in alignment, which means strength is integrated in the application of Pilates. For example, total knee strength, total arm strength, and total core strength are capitalized, whereas the weak muscles are facilitated by the stronger ones in the movement pattern. Another important concept of Pilates is the alignment. It targets the neutralization of the scapula, pelvis, and spine. The joints in the human body are stacked over one another. Example, the shoulder over the hip over the knee, and the knee over the ankle. The lumbar and thoracic curve are also neutralized while the pelvis is level. This concept is very important for alignment before we can actually participate in Pilates, or at least do any Pilates exercises. In Pilates, the body weight is maintained slightly forward onto the ball of the foot. The core is engaged with proper alignment, the spine is protected and engaged in more skill tasks. The stabilizer muscles of the spine is a multiplicity, and the transverse abdominis activate up to 100 milliseconds prior to limb movement, regardless of the limb direction. This is important when activity are done on unstable surface or during a single leg stance. The progression of Pilates was achieved by introducing the effect of gravity, base of support, length of the lever, and center of gravity. Eccentric and concentric contractions can be achieved by using the spring tension exercise on a dynamic format. Isometric contraction can also be achieved in a spring tension exercise, while eccentrically and concentrically contraction of a muscle dynamically. The core is very much emphasized in Pilates training. It is recommended to develop muscle endurance, strengthening to prevent low back pain, and help in rehabilitations. The lumbar stabilizer, the multi-DVD, are mainly type 1 fiber. So to improve its performance, low load and multiple reps are required to improve its performance. Putting all this together, Pilates requires motor function of the brain to control mobility and stability of the body, fire muscle activity, or a specific muscle group. The sequence of muscle activation and control its movement pattern.
What we'd really like to start by asking is, give us a little bit of a background on yourself doing the DPT and then Pilates, basically, which one came first, and you transition into the second one.
For sure. So I got hurt growing up in cheerleading and went to PT, and they did nothing for me. I didn't feel better, lump pain medicine. I skipped a lot of school due to pain, and weekend, inexpensive. It was just kind of like, here, like learn some Pilates mat exercises. I went even though I really would have rather done something else that weekend, but I just went because I was like, this will look good on my resume. Loved it. My body felt so good after a weekend of just moving, like really gentle movements and focusing on my core. I felt even better in my back, and I decided to go for my certification. And I actually did it during PT school, which was a lot.
I was going to say, how long did it take you to get your
So it's
certification?
6 months of weekend courses. I did it through Polestar Physical Therapy and Pilates in Miami, Florida, but they came up here and did a course through, and it's specifically for providers who do rehab. So I'll kind of start my treatment, reassess, talk to them a little bit how they're feeling, how they felt after last time, what they feel like helped, what they feel like didn't help, and half the time the patients aren't going to be able to tell you much, but you'll kind of go on your reassessment. I'll do some manual therapy, and then even something as like simple as a bridge can be done in a Pilates way, or something that's like 90-minute holds, like legs up into like a tabletop position. Those are all Pilates exercises, so you can do all of these on the bed, like you don't even have to get them up. So once you can get a patient down on a bed, then you can kind of do any type of Pilates exercises.
Okay, I suppose that was one of the, leading into another one of the questions that we have is how is Pilates done in a Pilates studio?
Yeah.
How does it differ from the kind of Pilates that you offer as part of a rehab for
So,
a patient?
interestingly enough, I go to a lot of different Pilates classes in the city to kind of be able to give recommendations to my patients for once they like graduate PT, like where I think is safe to go, where I don't, or like which instructors I think are good or not. I like the way it's done here in the sense that I have 3 PT days each week where I do PT with my patients, and then I have 2 Pilates days where I teach Pilates all day long. We have max 2 at a time, and we try and pair them up with similar ability levels. Sometimes it works, sometimes it doesn't. You just have to kind of go with the flow. But for instance, if I have 2 like chronic low back pain patients, I'll have both of them on the 2 reformers here. I'll see them in the middle. I'll tell them an hour-long Pilates session. It's basically like a private Pilates session, which is very expensive in the city, and insurance covers it because I'm a physical therapist. I'm doing PT with them. It makes people want to come to PT because they're getting this like really great exercise program, and by a licensed physical therapist, they know it's safe. They know that they're going to get a good workout, but also something that's safe.
So I think that makes people more excited to come here.
I know it does. Yeah, because I mean, think about like us who I don't know your history at all, but like we seem somewhat fairly able-bodied, right? To be like moving and walking here and all of that.
Probably not
It's
if you assess the
sorry, all of us. But if I did PT with you guys first, got you to where you are now, like say you're having chronic pain or even acute pain or whatever it is, instead of just discharging your patient to go pay a personal trainer or to go to a Pilates studio or to go back to spin, get them safe in an exercise program where they have good posture, they have good alignment, they know how to engage their core, they know how to lift both their legs up without sagging into their back or bearing down and not breathing like Valsalva, whatever it is. Teaching them to really go through an exercise program safely before they go out to the woods, right? But I think that people stay
Is there a certain, I guess, prior work functions that they need to do before they practice?
So I tell all my patients to go, I say, if you're having severe pain, let's do more PT first, then we'll move into Pilates. If they're fine, if they just have weakness, if they just have rapid range of motion, I get them right on the machine because we can do anything we can do on a floor, a mat, or anything on the reformer and more. And most people find that it feels better and they feel more secure, a little safer on that.
So earlier you mentioned about pre-PT days that you have with your patients.
Yep.
So on those days, do you have to do Pilates at all?
For
or
sure.
as part of the Pilates?
Exactly. So the way it's set up at my clinic here is that we have an hour-long session per patient, but we have a new patient every 30 minutes. So I kind of have done my treatment as I do the first 30 minutes and my trainer does the second 30 minutes. So if a patient is fully functioning, does not need hands-on or just needs a little like tune-up or something, right? We'll do a little hands-on or none, and we'll do Pilates. And then my trainer, I've taught her a lot of things to do very good at asking me questions if she doesn't know something. She is not trained in Pilates, but I've taught her a lot of things, and she knows things coming into this, and she runs people through stuff on the reformer all the time, and I'm right here treating you as you're on the reformer here. So I like to incorporate it in that last like 30 minutes. But like I said, if somebody's like kind of graduated but doesn't want to do a full hour up here because they want an opportunity to have hands-on, and they'll still see me downstairs where we have mostly treatment tables, and then like 2 reformers. We just kind of move in and out. I try not to have anything too structured because in the life of PT, things change so much, and people are 5 minutes late. People have to leave 30 minutes early, and you're like, what, you know, and or people are in crazy pain when they haven't had any pain for weeks, or vice versa, they're totally fine. And so kind of whatever you planned on doing that day will change the second the patient comes in. And you just have to be flexible and kind of go with the flow.
So you talked about having these like split sessions where you do 30 minutes, and you also do 3 days and 2 days. How does that work, being, you know, working within a physical therapy organization from a point of view of billing, insurance, and people being able to pay for these things?
Yep.
Do you have to set it in a certain way, or can Pilates be seen within the billing structure as part of therapies?
Definitely. So your question about billing and insurance and all of that. So thankfully, I don't have to call insurance companies and do all that. Some clinics you'll have to. I write in the minutes. Pilates can be used the same way any exercise would be. I bill under therapeutic activities, therapeutic exercise, or no re-ed anytime I'm doing Pilates work, depending on what I'm doing on it. So if I'm doing neuromuscular education, I'll bill for those minutes. If I'm doing like transfer training or like core engage or spinal mobility or anything like that, then maybe I'll do therapeutic activities. If they're kind of exercising on their own and there isn't really anything other than me just wanting to strengthen them, I'll bill under therapeutic exercise. Does that answer your question?
Yeah, no, it does. Because I was just wondering when I was looking into like the use of Pilates within physical therapy, whether you had to state that you're using specific machinery that's not relative to a PT setting because it's slightly different, you know, because obviously you need the objective kind of like.
However, it's the same thing as a spin machine, right? You have cables, you have different hands.
It's just set up in a slightly
Right.
different way.
But it's just that you're lying down for some of it or sitting up for some of it. Like it's the exact same thing. If I did, let's say, a leg press machine, the thing that your hand is next to right here, that's a foot bar.
Yeah.
You press out.
And you go back.
It's a leg press. I put hands in straps and I pull them down and their abs are engaged and they're working. Or you can do lat pull downs, right? Like you can. It's just in a different way. I can write every exercise as if it's on a reformer or if it's not, because you're using those muscles. You're doing different exercises, but it's on a reformer.
Yeah.
So I write when I do Pilates because I like to be as transparent as possible in my notes. So I write like Pilates reformer focusing on lower extremity stretches, core stabilization, spinal mobility, and then I write some of the exercise we do. Half the time I do Pilates lingo, and half the time I don't.
And it
Just
causes a problem.
no. And so there are 4 like, main apparatuses in terms of Pilates, which is the reformer, the chair, the Cadillac, and the barrel, which is right here. And I use the barrel and the chair the least, not because I don't love them, but because it's hard to do 2 at a time on it. As you can see, I'll offer this a little bit more. It's like a little more sprung. Not like my patients are lying down. They're good to go. Yeah. So in terms of doing 2 at a time, if I have like one patient who's maybe more advanced, I'll have them on the chair. If I have one person who just wants to gentle stretch or wants like light traction, just leaning over a barrel like that, it feels good in a child pose position. Lean forward if they feel better in sitting. Lean backwards.
So, do you find that some of the patients that you actually work with, you're offering them Pilates because you think it's a good thing for them, or do you think that some of the traditional forms of therapeutic exercises are less beneficial to them? And because then you're kind of like shading 2 different fields, 2 different professions.
I'd say both. I think that some PTs get stuck in very similar exercises and this is what you do for every single thing. And I will not be a PT for very long if I do that because I'm going to get very bored and I don't think that PT is they're scared that it hurts, and you're like, well, how am I supposed to do a clam?
Yeah.
You know what I mean? So like certain ways you can put their feet in the strap, you could do something different instead. And it's just, I think that Pilates benefits everyone. I have my 92-year-old grandmother do Pilates when I'm home, and I have professional dancers on here, and so it's a wide spectrum of types of people who are able to.
So how is your experience with patients of osteoporosis or who have fear of being
For sure. I find that at first the apprehension is high. I have less patients who are super fearful of movement, and honestly, I don't get them on here until they're ready, because I want them to feel very safe when they're on something that's super different. If they have a ton of fear of movement, I'll do a lot more like manual therapy or active assisted range of motion or gentle stretching on the bed. But if they're just like kind of don't want to exercise or don't want less of a fear and more of just kind of like, I don't really want to do this, which is more of what I see than a fear, they like this because they don't feel like they're in the gym. Some of my patients are like, oh, I hate the gym, like I hate exercising. When they're sore from working out on a Pilates machine, they're like kind of excited about it. You know what I mean? It is a difference. It is. It's just like, it's like if you love spin, you're gonna feel good after spin. If you hate running, right? If you hate running, you're gonna hate running. Like you gotta find kind of what patients like, and if they don't like Pilates, I can kick their butt downstairs on a TRX, or I can do something totally different. We just have to be versatile on what tools we have to use. If they hate Pilates, I'm not going to Pilates machine. Like, I find that that's more of a given.
Do you introduce the idea of Pilates?
Yeah, I do. Just because I think that it's very beneficial, and it's kind of what this clinic is based around. So I tell every patient about it, but not because they have to, but because I think it'll help. We have a lot of back patients here. We have some like sports injury patients here. We get patients who are post-surgical, like total knee replacement. I'll make sure they can bend to a certain degree before I put them on here, because it's awkward if not. I'm not trying to force anything, but if they can like go up a step, they can get a lot of patients with like upper body or neck pain haven't been lifting weights, haven't been doing squats, haven't been doing anything because they're scared. This, I can have them work out the rest of their body, or I can have them do really gentle motion or gentle weight. Exactly. And it gets them more stable, it gets them less fearful to be doing these little things, and gets them back to like their current function, or current function before the injury or before the pain started.
Just like I've been reading, like there's a kind of like a debate between like classical Pilates and type you do, and like where does one you think better for certifications?
So I do Pilates for rehab, and we do more neutral spine, more contemporary Pilates. I find that classical Pilates is more tucked with a flat back, like imprinting the spine. Classical Pilates also starts the same way, has the same middle and the same end. My patients tend to not like that. My patients want something that ebbs and flows depending on how they're feeling. They want to change weight, they want to switch it up the same way you would in a normal Pilates class that you would go to like outside of here. Have any of you tried Pilates before? Okay. So if I start you out with the same thing this whole time, like why can't I just like do this by myself? So I do, certain patients who have like that need that posterior pelvic tilt, that have low back pain, that maybe have some stenosis or just feel better with a little bit of a tuck, I'm okay with that. But we don't walk around with a tuck, like we don't walk around our whole lives like in this tuck position. So I like to exercise them in a neutral spine, because that's how you should be sitting and that's how you should be standing. I want to strengthen you in the way that I want you to be upright. So I do like Pilates for rehab, or contemporary Pilates. However, I wouldn't say that like blanket one's better than the other, but obviously like when you do, the reason you do it is because you think there's like a benefit to it, or you think it's a little bit better. So if you want to come closer, do that, and then I'll just kind of name what's going on.
Okay.
This is the carriage. The carriage moves in and out along the tracks. This is the foot bar, so put your feet up here for me. And then these are the shoulder blocks. The headrest goes up and down, so depending on what your patient feels most comfortable with bridging, I always have the headrest down so you don't like crank into the neck. but I find that it's more comfortable to have it like a little up for your patient. If your patient is, I'll lower you down, come down. If your patient is like this when they're on the machine, you're gonna have to lift them up. If the patient's still like that, you just lift up and you give them a little pillow. And whatever feels most comfortable to the patient is kind of what I do. Which position do you feel most comfortable in? Are you good here? Yeah. Okay.
I can tell from here.
So these are your foot straps. They turn into hand straps. There's a little hook right here. So we're not gonna do it yet, but basically I can have both her feet in here. We can do a lot of things that I'll show you in a second, or you can just stretch. Hold this for me for a second. The springs are what determines the weight. Certain things, less weight is harder. Certain things, less weight is easier, depending on what direction you're going in. Press out with this leg. So press the carriage all the way out. And put your foot in here. So, hamstring stretch. If you pull the toes back towards you, pop the ankle, you can feel like sciatic nerve glides. You feel the difference. In here. Out to the side, inner thigh stretch, cross it over the body. You can do hip flexor stretch by bringing it down and bend the knee. Come off the edge. Do hip flexor stretch. What I look for is not having too much of a gap here, but telling them to press the toe back into the mat. If you don't feel a stretch, bend the opposite knee, bring the carriage in. Feel more of a stretch? Okay. So you can really modify it to anything. Patients who have a lot of lordosis, I tell them press your back firmly into the mat before you even bring that leg in, just so that they don't arch too much. Press all the way back out, lift your leg up. All right, so bring the carriage all the way in. What I start with almost every time, just because sometimes I'm between patients or I'm just trying to have somebody, I just like to start the same way, mostly because my patients get used to one way, and I just want them to get used to the machine, do a couple pelvic tilts back and forth. So you're tucking under, pressing your low back to the mat, and then dropping your tailbone down, arching your low back. Good. Do it a couple times. And then I just say neutral spine is the middle of those two. So I want you to be able to have a blueberry underneath your low back. Don't smush it and don't let it roll out. Okay? Engage the core, press your heels all the way out to almost a lock position, and then slowly come back in. And you can feel how it's like a leg press, basically. So pressing.
Lower back, L4, L5. My second joint. I don't know how I damaged it. Well, it counts as a problem on my side joint. The L4, L5 was actually getting to the bus. It's the step, it's the high step.
Don't hit your patient with the strap. Alright, now use this, engage your core, press your leg all the way out, and float this one up. Right here. Good. So now, straighten both. Don't make me do all the work. Okay? Good. Keep your feet together. Which one's longer?
They're not long. My left one seems longer.
Okay. So now, lower this a little bit. Wiggle around. See if you're even. There you go. Better?
Yep.
Good. So now, engage your core. Fold at the hips. Lift your toes up towards the ceiling. So keep this down. Fold here. So wait, relax. Totally relax. Lift your legs up. That's what I want you to do. Okay. Keep the core engaged. Press your heels down slowly. And come back up toward my hand. Control it. Nice. And all the way down. Now turn out a little bit more. Kiss your heels together. Don't let them go. Lift up. And come back down. Now we're going to do leg press again, but it's in the straps, so he has to do a lot more stabilization through his core and his pelvis. So don't worry, don't over tense. Come up a little bit.
I'm just trying to get my body in the right
Alright.
position.
Bend the knees. I find that too many cues sometimes makes them not be able to do it because they're too in their head. So just relax, come in, press your heels out towards the door. And I'm just guiding him right now because he's not used to the machine. And press out. And I'm going to slowly let go of my grip so that he learns how to stabilize through the equipment. Press all the way out.
So you never leave the patient without supervised?
Not never. I would never leave him. today, like this.
First,
Yeah.
He's a danger to himself.
You are.
I know.
You're gonna hurt yourself on the, you know. If they can do this whole class by themselves, I'm right here. I'm yelling out cues, but I might not be touching them. And I have 2 at a time. I'm definitely not giving this much tactile cue. Good. One more time. Hold. Does that feel good on your low back? Okay. So hold here. Just relax a little bit. Bring your knees down lower towards your chest. Gives the patient a stretch that they feel safe and comfortable with. This one's gonna be a little harder for you. You'll be okay. This is gonna open up your hips. It's gonna feel great. Press all the way out. Straighten the legs. Lift up. Don't let me hold it. You hold it. Okay? Open your legs. Big leg circles coming down and around. And down and around. Up. I'm gonna let go. Control it. So you feel your inner thighs working. Opening up the hips, increasing hip mobility, working each side of the hip. Relax the shoulders, open up the collarbones, make a little more circle. You got it. Good. So now we're gonna reverse it. Press it straight down towards the springs,
Okay.
just like you did.
Yeah.
Go on, go on. Open up
And go the other way.
and go the other way. Some people have one side, one direction that's easier for them. You'll kind of get to know which side is more control or you can use props like a ball or a Pilates ring or something like that too. How are you feeling so far?
I'm feeling worked.
And this is very gentle, very simple exercise, and he's feeling worked. So it's like, you can feel this in a lot of patients here.
This randomized controlled study specifically looked at incorporating Pilates-based exercises with people recovering from a total knee replacement. Early periods of recovery after a total knee replacement, it's important to focus on the stabilization of the trunk. It's common to see impaired balance, changes in gait, and postural sway because of decreased muscle strength. All of these factors put patients at risk for fall, which can lead to serious injury or even death. Other goals are to decrease pain, increase range of motion, and increase muscle strength and balance. Many older patients avoid these exercises because of pain. However, using Pilates may increase the patient's tolerance by having them focus more on their breathing concentration principles, which take away the focus from the pain. So the specific aim of this research study was to look at the effects of the addition of a Pilates-based exercise program on balance and quality of life. So this study took place over the course of 6 weeks, and it concentrated on 6 principles of Pilates. The first being concentration, the second control, the third centering, 4 flowing movement, 5 precision, and 6 breathing. The patients were taught how to activate their transversus abdominis as well as their multifidus muscles by using biofeedback. They were asked to perform all exercises without swaying their lumbopelvic region and with breathing control and full concentration. The goal for both groups, the Pilates group and the control group, was to strengthen the hip and knee muscles, attain knee flexion of 110 to 100 degrees flexion, and restore full knee extension. So the results of this study showed that adding Pilates in addition to standard exercises were significantly more effective at improving balance and physical function. Some of the specific exercises that were used were the clamshell and the shoulder bridge exercises. The group that performed these exercises were more effective at hamstring and gluteus medius muscle activation as compared with the regular hip strengthening exercises that were performed in a standing position. So in conclusion, Pilates-based exercises are appropriate for rehab programs following a total knee replacement because they involve the entire body. They can be combined with breathing exercises, and they can be used with older patients with systemic diseases and general muscle weakness.
So for my research article, they looked into how Pilates can help elderly patients improve their balance as compared to conventional balance training. Some diagnoses that they said that this could be used for were disc herniation, spondylolisthesis, lower back pain, and scoliosis. And it also helps with instability of the shoulder and scapula, the knee, or the ankle, as well as ACL repair, meniscectomy, joint replacement. Pilates is useful in the orthopedic setting because it can aid in therapeutic exercise and neuromuscular and postural re-education by increasing muscle balance and symmetry, strength, flexibility, proprioception, and range of motion. Additionally, Pilates incorporates both concentric and eccentric movements in a variety of positions in both open and closed chain. The study was a randomized controlled trial of 51 nursing home residents who were divided into three groups that each met for 3 times a week for 6 weeks. The Pilates group performed lower extremity strength and flexibility exercises to improve coordination. This consisted of 45-minute group sessions, 10 reps per exercise with 2 minutes rest in between. The conventional balance training group underwent trunk and lower extremity exercises, focusing on flexibility, strength, endurance training, and postural control. They performed these exercises in different positions and on different surfaces. And the last control group only had a 5-minute warm-up, 12 minutes of walking, and 5 minutes of cool down. The results show that the quality of life as well as functional balance increased significantly in both the Pilates and conventional balance groups when compared to the control group, but the Pilates group had higher scores in terms of the functional reach test, timed up and go test, dynamic gait index, and RAND 36 survey for quality of life. They propose that this may be due to the fact that since in Pilates you have to maintain your balance as well as control your breathing, it promotes multitasking, and Pilates also facilitates the production of serotonin in the brain, which can help them enjoy the activity more. Some negative aspects of Pilates include it's not always feasible to deliver the intervention in regards to space required for the equipment. Proper body position is a key part of Pilates practice, so there's always a need for constant early supervision to ensure that they're doing the movements correctly. And although there are modifications for the types of Pilates movements based on ability, patients tend to report shoulder and knee pain as well as some wrist pain when they hold the positions. And in accordance with that, even though there are modifications, not everyone has the required functional ability to even begin Pilates intervention.
I'm Andrew, and today I'm going to talk about the use of Pilates exercises in help changing the bone mineral density for patients who have osteoporosis. The reason why I chose this topic is because while in clinic, I've identified there are a lot of patients that are coming through the doors suffering with these kind of conditions, lower back pains, osteoarthritis, osteopenia, osteoporosis. So the article that I chose is called The Effects of Clinical Pilates Exercises on Bone Mineral Density, Physical Performance and Quality of Life of Women with Postmenopausal Osteoporosis. I chose this because the United States population shows that 44 million women and men are currently subjected to osteoporosis or have low bone mineral density. This represents a 1 in 6 of the population, and also represents 55% of plus 50-year-olds having this condition. So the lowering of bone mineral density leads to weakness in the structures of the bones, and this subsequently has a disrupting effect on musculoskeletal positioning, weakness, and also increases fall risks. So I thought this is a really important thing because this is a lot of the things that we're going to see while we're in clinic. To look at whether Pilates could be used primarily as a way to improve low bone mineral density in postmenopausal women. The study group that I was represented was 41 patients who did a 24-week exercise program. This exercise program consisted of 8 weeks of different Pilates exercises and was preceded by a warm-up session and concluded with a cool-down session. The study group was 22 people and the control group was 19 people. What they identified at the end of the exercises was through taking measurements on a visual analog scale for pain They also did a DEXA, which is a dual energy X-ray absorptiometry measurement for BMD, and that was taken at lumbar-pelvic region. They also did a quality of life evaluation and a 6-minute walk test. And in all of these areas, the group that were represented as doing the Pilates exercises and just against the regular exercises of the control group, there was increases in all of their results. What I took from this is that the results of low impact Pilates had beneficial properties in increasing BMD of this group of patients, as opposed to those who were not under such guided tutelage. What I learned from the article was that physical therapy and Pilates are also already intertwined, even though the levels of qualifications are different. Many of the exercises that were used are repeated throughout both industries in various manners. And what is apparent is that the response to significant health problems, such as osteoporosis through exercise-based Pilates, is a special tool in reducing the amount of cases we will see from secondary fractures. The improvement in increasing osteoblastic conditions and postural stability through strengthening and stretching exercises has an impact on increasing BDM, lowering pain and improving the quality of this population. The quality of life. Pilates is a useful tool to combat the effects of OP. Not only does it lead to increases in the bone mineral density, it lowers pain throughout, creates a general feeling of wellness as well. The negatives to my research is it failed to address what exercises the control group were provided with regards to the exercises. It would have been more influential if the Pilates exercises were more specifically related to Pilates and did not cross over into the world of physical therapy, say using a reformer, as did our interviewee, Dr. Mims.